in hydroacanthoma simplex, if you spot these cuticle-lined ducts, then it implies that this is a clone of the acropharyngeal keratinocyte. So at the end of the day, you have to be looking very carefully to make sure that you're not missing those ducts, because that's going to be the difference between a hydroacanthoma simplex and a clonal seborrheic keratosis. Now, hydroacanthoma simplex is basically just a superficial poroma. So definitely go back to your adnexal chapters and study the difference between hydroacanthoma simplex, which is more simple and superficial. And then as you get thicker, you're going into your poroma. As you start to form a deeper dermal proliferation, there's no overlying connection. That's a dermal duct tumor. And then you can have your nodular hydradenomas, which are more solid and cystic proliferations with these clear cell poroid proliferations, areas of hyalinization, et cetera. And the most important thing is whether or not you're determining it's clonal SK or hydroacanthoma simplex is to make sure that you're not missing a squamous cell carcinoma in situ or Bowen's disease. So from low power, they can look very similar, but you're going to have scattered atypical nuclei and mitotic figures. If you find mitotic figures really high up in the epidermis, that's a worrisome sign. If you find the loss of the granular layer, that's also a worrisome sign. Many times you'll have a rim of normal keratinocytes, but in my experience, there's a wide range of expression of Bowen's disease. You may have some that look like they have no HPV influence, and you may have some that look like there's a lot of HPV influence. So squamous cell carcinoma is not homogeneous, and what you will see is a wide range of expression of intraepidermal full thickness malignancy, which is Bowen's disease. So it's kind of a catch-all term, but just make sure that you're not going to miss a malignant proliferation. And it's important because you can have malignant transformation even in some benign areas of skin. So and as I said, inflamed hyperkeratotic seborrheic keratosis, if you just got the superficial part of this, it would be difficult to tell the architecture, exactly what's going on, the fact that this is a flat-bottomed proliferation, that it seems to be respecting the adjacent, if you could see in the picture, the adjacent skin, the level of that skin. So it's not endophytic growth, but if you just got the superficial part, you may not be able to say, and in many cases, I'll just sign it out as descriptive and say that it's unclear exactly what the architecture is and what I favor. So if I see that most of the keratinocytes are not malignant in cytology, then I will say that, but say at the end of the day, you have to go back to the clinical. If there's any residual, clinical correlation is recommended. And if it clinically behaves badly, starts to grow, evolve, then getting a wider sample or a larger, more representative sample to make sure that you're not missing a malignancy. Verruca vulgaris can present many different ways as well, but some of the key features are papillomatosis architecture, this elongation of the epidermis, as well as a parallel elongation of the reedy ridge with dilated vessels. The dermal papilla with dilated vessels, and then the corresponding reedy ridges. And you've got clear cell changes. You've got punctate basophilic granules. You have towers of perikeratosis with intracorneal hemorrhage. And if you go on high power, you don't find severely atypical mitotic figures or high elevated mitotic figures. And low power, the architecture of this inward buttressing of the outer part of the epidermis can also be very helpful. You can imagine if you just get a superficial portion of this, then it may be 100% difficult to tell that you don't have something else going on below. And that's because there's a lot of HPV influence in squamous cell carcinoma and hypertrophic actinic keratoses. So you can't truly know if you don't have the whole sample, if this is an HPV influenced malignancy or pre-malignancy, or is it just a pure verruca? And if you throw an inflammation in there, and you've got a really kind of perturbed or distorted architecture inflammation, it can be really difficult as well. So at the end of the day, the pathologist is going to have to communicate what we see both architecturally and cytologically And if we don't have a good representation and it's broadly transected, then to let the clinician know that and closely monitor the patient, getting more of the entire lesions better to increase the confidence of diagnostic accuracy. Many times, if you have a chronically irritated seborrheic keratosis, you start to get these whorls of keratinocytes called squamous eddies. Notice again that you don't have true parakeratosis here. So these are not keratin pearls. These are just whorls of keratinocytes in that squamous eddy. These are like spindled keratinocytes in between, and then these whorls, you can almost imagine like a whirlpool of skin cells just kind of twisting. You also see the horn cysts, again, orthokeratosis, not parakeratosis predominantly. Seborrheic keratoses are representative in many different ways in dermatology. One of the common ways that we see the presentation of seborrheic keratoses are dermatosis papulosa nigra. These are multiple seborrheic keratosis of the face. You often see them in patients with a higher Fitzpatrick skin type or African-American descent. There is a syndrome associated with rapid onset of multiple seborrheic keratoses. You remember this from step 1, but Lesser-Charlotte syndrome. It's associated with malignancy, primarily GI malignancy, also lymphomas and leukemias. It's also important, though, if you do see people with a lot of seborrheic keratosis, that you don't mention, hey, you might have a malignancy, but just gently remind them, depending on their age, that age-appropriate malignancy screening is recommended in primary care. And so just to double check and make sure that they're being appropriately screened for their age. Dowling-Dagos is a disease not to be confused with Dagos disease, but Dowling-Dagos disease, where you can see reticulated pigmented anomaly of the flexures. And these lesions look very similar, if not indistinguishable, from reticulated seborrheic keratoses, and they kind of follow the adnexal, the pilosebaceous units. This is a mutation, an autosomal dominant mutation in keratin 5. So here we have Morgan Freeman, and he has the dermatosis papulosa nigra, or the DPNs, as we call them for short, just these scattered seborrheic keratosis on the face, the cheeks, etc. And many times my patients, if they've never heard of it, they come in, they're concerned about it. What is it? I will often mention that Morgan Freeman has these as well, and they know exactly kind of what I'm talking about. They can be cosmetically removed, but I try to remind my patients that this is a very natural look. We know that this is just an expression of normal growths on the skin, and that anything that we do to necessarily take them off may leave some lighter pigmentation that looks more unnatural in the area. So at the end of the day, we just try to focus on acceptance of these lesions. And if you notice one is growing more abnormally, or there's something different about it, then that would be the time to actually take a sample. Let's search for a lot. This is just the representation of multiple eruptive seborrheic keratoses that can be associated with a malignancy. Epithelial strands and horn cysts extending from the follicles. This is what you will see in Dowling-Dagos. So looks like sideways reticulated seborrheic keratoses running along the follicular units here. Again, just higher power. Looks like a reticulated seborrheic keratosis, but it's following kind of along the follicle there. Lichen planus-like keratosis is one of my favorite diagnoses. It's called AKA benign lichenoid keratosis. And the reason why I like it is because many times clinically it looks like a basal cell carcinoma. And it's always a pleasure to let the clinician know and the patient gets good news that it's not a skin cancer, but it's a benign lichenoid keratosis or lichen planus-like keratosis. I will mention to you there is a diagnostic pitfall in lichen planus-like keratosis that can be disguising melanoma in situ. And so I will talk about that briefly, because many times I will really critique these lesions and make sure that there's no melanocytic proliferation that's being regressed within these LPLKs or BLKs, as they're called. You often we'll see this as it's an attempted immunologic regression of lentigo or seborrheic keratosis or other acanthoma. That keyword of regression tells you that this is an immunologic pattern, a lichenoid inflammatory pattern in a lesion. And so you can imagine that regressing melanoma in situ could look very similar. And so that's why if the clinician's worried about a pigmented lesion, then I'm really going to do the stains and make sure I'm going to do SOX and PRAME and look for any kind of hidden melanocytic malignant proliferation within that. You're going to see this on the upper trunk and extremities most often as a regular hyperkeratotic plaque. You'll see hyperkeratosis, hypergranulosis, and interface activity. Again, you got to look to the edges to see, do you find normal lentigo or normal seborrheic keratosis? So that way you will have more confidence. Okay, I'm dealing with that. That's what's being inflamed. So this is on high power. It may be hard to orient yourself, but from low power, you'll see a broad lichenoid inflammatory infiltrate. Here in the epidermis, you're seeing serum containing elements. There's a lot of inflammation. There's leakage of serum and blood components out into the superficial epidermal space. You see the destruction of the basement membrane. You often can see the same type of destruction in lichen planus. So lichenoid interface dermatitis, sawtooth reedy ridges, savate bodies, etc. Here's a nice low power view or moderate power view from McKee's pathology, which shows this really broad, dense lichenoid inflammatory infiltrate, an obscuration of the dermal epidermal junction, maybe some focal extravasated erythrocytes, some wedge-shaped hypergranulosis and hyperorthokeratosis rather. And you may see some scattered savate bodies. So if it said rule out basal cell, then this is probably just your typical BLK. If it said rule out melanoma or rule out regressing melanoma, then doing stains to make sure that you don't have some hidden SOX positive contiguous growths or PRAME positive contiguous growths is important. I've found some sneaky regressing melanomas that way. And so I highly recommend, if there's any suspicion at all, just to do the stains and make sure. Most of the time, the BLKs are just BLKs. If they look like a BLK, it is a BLK. Higher power to show you just scattered savate bodies here, some melanophages dropping out into the superficial dermis. So you may have heard of melanoacanthoma. I feel like the term's kind of going out of style. It's kind of more of a pigmented seborrheic keratosis or pigmented clonal seborrheic keratosis, but you'll see this is more of a rare type, but I've signed this out within the last year for sure. So it's a variant of seborrheic keratosis. It looks like a dark seborrheic keratosis and histologically looks like a seborrheic keratosis, where you see compact hyperkeratosis and parakeratosis along with keratinocytes and the keyword dendritic melanocytes. So there's just a ton of dendritic melanocytes throughout the acanthotic epidermis. These often lack horn cysts, and like I said, they may be clonal. You may hear the term oral melanoacanthoma or melanotic macule. That's an unrelated entity. So again, I hope you can appreciate just you can even see without staining these ubiquitous presence of dendritic melanocytes. And so if you've got an acanthotic epidermis and you have just pigment almost contiguous throughout with these small little dendritic processes from the melanocytes, then you may be dealing with a melanoacanthoma. This is from Dr. Elson's textbook. If you do a SOX stain, it would highlight. I would like to do a SOX red stain many times just to highlight the density of melanocytes there. The important thing is that there is no melanocytic atypia throughout. These are all really mature. So you're not finding a typical contiguous growth of immature looking or dedifferentiated melanocytes. And if you did a PRAME on this, it should be negative as well. Clear cell acanthomas are solitary red-pink slow-growing papules, sharply demarcated. You can see parakeratosis in them, absence of a granular layer. So that sounds a lot like psoriasis, doesn't it? And peppered with neutrophils. There's so many things that share in common psoriasis and clear cell acanthoma, actually. But again, this is just a lesion. One of the hallmarks is that pale, clear keratinocyte cytoplasm retaining glycogen within, and the defect in phosphorylase is the test question they always want you to know for clear cell acanthoma. Usually this change of pale or clear keratinocyte cytoplasm spares the basal layer and the adnexa. In the dermal papilla, you'll find dilated capillaries as well. So honestly, I think that they would test you on this because they want you to go to the edge of the specimen and look at that abrupt border between pale and normal cells. So I will tell you, I think it's very high yield to be able to recognize the clear cell change, go to the edge and see that abrupt transition. It's an easy question that you can get correct as long as you're looking for it. You can see the dilated vessels in the dermal papilla as well. And in those areas where you've got neutrophilic crust, diffuse parakeratosis, a diffuse hypogranulosis, suprapapillary plate thinning, it looks a lot like psoriasis, doesn't it? So, but again, clinically, you'll know it's lesional. Usually psoriasis has more regular psoriasiform hyperplasia where you've got more rounded out reedy ridges. And clinically, the scenario is going to be 100% different. But if you didn't have any clinical scenario, and I often find that these clear cells are just a lot more clear than what you see in psoriasis typically. But just to point out that it's interesting, it has a very similar appearance in many ways to psoriasiform hyperplasia. So we talked about clear cell acanthoma, where you have that abrupt border between pale and normal cells. People may think it looks similar to a trichomoma, where you also have those clear cells that are recapitulating the outer root sheath, but you don't see that thickened eosinophilic basement membrane material on the outside of this as you would in a trichomoma, which again, remember, trichomoma is an adnexal tumor, so remember to cover your adnexal tumors. Large cell acanthoma is a diagnosis that I don't make a lot, but I used to make it a lot in fellowship. We had kind of this at Cleveland Clinic, pretty high volume place. We would often get lesions that you couldn't call them anything else essentially except a clear or a large cell acanthoma, because clinically they were definitely an acanthoma and they may look like a lightly pigmented patch or plaque. And histologically, you can tell that they're a neoplasm because they're sharply demarcated. And you see some hyperkeratosis and some hypergranulosis, but you often have retention of the granular layer. Everything looks normal in terms of you don't have a lot of atypical keratinocytes necessarily. Well, you don't have a lot of like atypical mitotic activity necessarily, but the cells are atypical in the sense that they're larger. So usually they're larger than keratinocytes, even on the order of twice as large, but they retain a nuclear cytoplasmic ratio. So here you can see a large cell acanthoma clinically. And if you go on higher power, you'll see maybe some adjacent solar lentigo changes and some larger keratinocytes. Pretty good retention of maturation. In this one example here from Dr. Elston's book, you can see some patchy retention of the granular layer and some orthokeratosis kind of mixed in with a little bit of parakeratosis. In reality, it may be difficult to tell the difference between an actinic keratosis in this situation. Here's another example from McKee's textbook where you've got this retained granular layer throughout and overlying orthokeratosis. So you wouldn't really want to call it an actinic keratosis because you're not seeing parakeratosis, you're not seeing the loss of the granular layer in many ways. And these cells look large, but they're not, it just doesn't look like an actinic keratosis necessarily. Now, that being said, in real life, these are probably diagnosed as pigmented actinic keratoses. But if you know that you're looking for this specific entity, you may be able to entertain this diagnosis, a large cell acanthoma. The other thing is important to rule out melanoma. So clinically, this may come in as rule out macular seborrheic keratosis, rule out solar lentigo, rule out melanoma in situ. So being able to rule all of those things out. So doing a SOX10 stain, making sure that these are not abnormal melanocytes, et cetera, and you're not dealing with a melanoma in situ, that's all going to be extremely important. So here's a kind of a side-by-side comparison between a large cell acanthoma, which we just looked at, and a pigmented actinic keratosis. So you see the atypical cells are really kind of concentrated and hyperplastic. There's a lot of crowding at the base. And then you still have some maturation. It's not full thickness atypia. So you're not getting Bowen's disease, but you also have overlying parakeratosis here. So this is and there's scattered melanin throughout the epidermis, which is a little hard to appreciate in this picture, but it's a pigmented AK, for example. Moving on to inverted follicular keratosis. This resembles an expanded hair follicle. It's an endophytic lesion. It's kind of an upside down seborrheic keratosis extending down through the follicle. You will see finger-like projections and smooth borders. Basaloid and squamous cells can be found as well. Usually the basaloid cells are at the periphery and the squamous cells are towards the center of the neoplasm. You can see squamous eddies as well. So notice at low power that follicular extension and the endophytic proliferation. You've got kind of a complex architecture. And if you just were to shave off the top of this here, a derm path may be worried about the endophytic nature, but this is a nice representative excision, essentially, to really illustrate this inverted follicular keratosis. On higher power, you're going to see a lot of squamous eddies as well. Now, this is easy for someone to misdiagnose as a squamous cell carcinoma. It's important to get in on high power and make sure there's really no significant mitotic activity or nuclear pleomorphism. And what you really have are just abundant squamous eddies. It's endophytic, that can be worrisome, but if most of it is bland and you've just got some squamous eddies and a true lack of parakeratosis keratin pearls, and you're not seeing malignant acanthosis or malignant acantholysis pattern, then you're probably dealing with an inverted follicular keratosis. The other thing is, if this is broadly transected, it's good to describe what you're seeing and say, you don't know what's going on underneath, because at the end of your sign out, you have to protect the fact of possibility that there could be something going on below that level, and to let the clinician know that so that they can follow or even go back for a deeper biopsy. Encourage the clinician to rule out the malignancy in that case. Warty dyskeratomas, these are fun diagnoses to make because they occur in middle-aged elderly patients on the head and neck. They can be a solitary papule with a central pore, cup-shaped invagination. And clinically, there may be some concern, obviously, for squamous cell carcinoma. So you have to have a high degree of suspicion on these. Prominent acantholytic dyskeratosis and suprabasal clefting within the villi. So the way that you're going to know it's a warty dyskeratoma as opposed to a squamous cell carcinoma is it's very well circumscribed here. So it's very symmetric and cup-shaped, and you can see the acantholysis, you can see the dyskeratosis as you would see in Derrier's disease. It's almost a localized Derrier's disease. So this is one lesion, it's not a rash, but definitely prominent acantholysis and dyskeratosis, which you can appreciate in higher power on this image from Dr. Elson's book, which shows these core rons here, these circular keratinocytes with basophilic and eosinophilic rims. You can also have grains, which are the flat, like rice-shaped basophilic grains. And what's important to note, you don't have a lot of nuclear pleomorphism. You don't have a lot of mitotic activity. Relatively bland, all things considered. You can see some spongiosis, and it may be inflamed. And your first impression may be to think, well, this looks like acantholysis in an acantholytic squame, but just go closely and make sure that it's not a warty dyskeratoma, because this essentially is the acantholysis and dyskeratosis that you see in a warty dyskeratoma as well as Derrier's disease. Pointing out these core rons again, acantholysis, dyskeratosis. The villi are these so-called villi. They're just protrusions that look like villi, as you might see in the small intestine. They're that well delineated and demarcated here, but lots of dyskeratosis above the level of these basal keratinocytes, the acantholysis and the dyskeratosis in a warty dyskeratoma. More examples of core rons. They're fun to look at. And it, like I said, if this were a rash, you would be thinking Derriers. Derriers presents as itchy, greasy, crusted, keratotic, yellow-brown papules, so-called keratosis follicularis. And these papules and plaques usually occur in the seborrheic areas of the body, as well as the flexures. In this disease, you have peak onset around puberty, often following sun exposure. The mechanism they like to test you on is an autosomal dominant mutation in ATP2A2 gene encoding the circuit A2 endoplasmic reticulum calcium pump. So it's a mutation that causes sequestration in calcium in the ER, leading to impaired synthesis and folding of the cell adhesion proteins. This leads to acantholysis and dyskeratosis, as well as apoptosis of the keratinocytes. Acantholytic acanthoma is a localized area of hyperplasia and hyperkeratosis. You see acantholysis, suprabasal or subcorneal clefting, dyskeratotic cells, and you might see what looks like a vesiculobullous disorder, but the clinical doesn't fit that. So it's a solitary lesion. So anytime you see acantholysis, you'll be thinking about, is this some type of acantholytic neoplasm or acantholytic squamous cell carcinoma, acantholytic acanthoma, warty dyskeratoma? So you see the pattern, but you can also think about pemphigus or other types of auto antibody mediated bullous eruptions, which we cover in a different lecture. So think about the similarities and differences there. Here you see the hyperkeratosis, the acanthosis, and the acantholysis. Again, this is an acantholytic acanthoma. Now, if this were a part of a rash, you would think Haley, maybe pemphigus, maybe Grover's. The key to this is that you, in Haley and pemphigus, you don't have a lot of dyskeratosis. You have more acantholysis, but you don't have as much dyskeratosis. Grover's, there's many different variants of Grover's or benign transient acantholytic disorder. So sometimes you may have Grover's that looks like Haley. Sometimes you may have Grover's that looks like pemphigus, et cetera. We cover that in a different lecture. So for the sake of time, we won't go over everything here. But how does Haley present? Just to remind you, with flaccid vesicles that easily rupture and give rise to macerated and painful crusted erosions in the intertriginous areas most commonly. And what is the disease mechanism for Haley? Well, it's autosomal dominant. It's a genetic defect in ATP2C1 gene. That's a calcium pump that forms the SPCA1 protein on chromosome 3. And this is an ATPase in the Golgi, which leads to defective calcium sequestration into the Golgi and impaired processing of proteins involved in cell-cell adhesion. Epidermolytic acanthoma. If you know what epidermolytic hyperkeratosis looks like as a pattern, this is a single lesion that has that pattern within it. So solitary or multiple papules, which may resemble seborrheic keratoses, but you see this kind of lytic change to the keratinocytes throughout with overlying hyperkeratosis. This appears as coarse, irregular hypergranulosis associated with disruption of cell membranes, and it spares the basal layer. So here you see epidermolysis and epidermolytic hyperkeratosis, where you've got these clear, almost vacuolation that just destroys the architecture of the keratinocytes, and overlying hyperkeratosis. Now, you often will see epidermolytic hyperkeratosis as an incidental finding in many different disease entities or skin specimens. So if you see it, it may just be an incidental finding that's not relating to the other pathology in the specimen. You could mention it as well. It could be important if the patient starts to have a lot of these areas of epidermolytic hyperkeratosis, then the risk of their offspring having a full-blown genetic defect associated with keratin 1 or keratin 10 mutations leading to epidermolytic hyperkeratosis is possible. So it may be useful data to at least mention in the comment, but not to make a huge deal about it if it's just one single lesion. Higher power view showing that punctate kind of granular eosinophilic and basophilic material, abundant kind of empty spaces or vacuolation changes, and overlying hyperkeratosis. Moving on to epidermal nevi, these are present or near birth in a linear Blaschko line pattern. It's associated with mosaicism as well as loss of heterozygosity or lionization. Patients with multiple of these may have other organ involvement, so that's important to recognize clinically if you're looking for some syndrome. Referral to genetics or looking for other presentations of syndromes would be important, and if you do see a lot of epidermal nevi in a patient. They resemble seborrheic keratoses clinically as well as histologically. Inflammatory linear verrucous epidermal nevus is a kind of subtype of epidermal nevus. It presents as very pruritic, scaly, and erythematous linear plaques. On histology, you'll see alternating orthokeratosis and hypergranulosis with parakeratosis and hypogranulosis. If you go from left to right, you'll be able to see that transition. It may remind you of kind of a checkerboarding pattern, which you may remember back to other types of inflammatory diseases like pityriasis rubicularis, but this looks different clinically. And so if it's linear and it's presenting with the alternating ortho hyper and para hypo, then you can think about an Lichen. Commonly tested as well. You will see variable acanthosis and papillomatosis and variable spongiosis and exocytosis of lymphocytes. So from low power, you see the alternation of blue and red corneum, as Dr. Elson's book mentions, but orthokeratosis and parakeratosis, as well as hypergranulosis, usually right below the orthokeratosis, or hypogranulosis right below the parakeratosis. Another example of that papillomatous nature with the alternating ortho and para, as well as hyper and hypogranulosis. It's also inflamed. So you may or may not see a lot of inflammation in Lichen. That's not necessarily going to nail the diagnosis. It's more about the clinical with the linear distribution along Blaschko's lines. So we talked about Blaschkoid distribution. There is an entity called Blaschkoid epidermolytic hyperkeratosis. It's mosaicism for keratin 1 and 10. And this is what I was talking about. If you do see something in a patient that is diffuse epidermolytic hyperkeratosis, to mention it, resembles epidermal nevus clinically and EHK histologically. But the important thing to note, and for your exams as well, is the patient can pass on this mutation and have a child with generalized epidermolytic ichthyosis. This is more likely if these if there's widely separated lesions involving different parts of the body. So like I said, if you do see it, just to mention in the comment, because this could be starting off a pattern for the patient. Next, we will briefly touch upon the high yield cysts that you should know in dermatopathology. So with any cyst, if you determine that you're dealing with a cyst, you got to think about what's the epidermal lining. And once you determine the epidermal lining, what are some associated features around that lining to help you make the diagnosis? So this chart can be for your self-review. We'll go through some examples here. So epidermal inclusion cyst, also known as epidermoid cyst or infundibular cyst, is lined by stratified squamous epithelium showing epidermal keratinization. Retention of the granular layer is key to making the diagnosis, and there are no adnexal structures directly connected to the lining. If there was, that would be a dermoid cyst, and we'll talk about that. Epidermoid cysts contain loose lamellar keratin. It looks kind of like onion skin keratin or basket weave orthokeratosis. It looks like shredded wheat in many cases as well. So loose lamellar onion skin keratin. Clinically, we often see, and histologically, we will get ruptured cysts. So you can see granulomatous inflammation surrounding it, fragments of keratin that appear as potato chip cells, as they're called, or they almost look like certain like flakes of cereal. They've got these kind of clear areas with like linear keratin fragments, which you will see a lot associated with that granulomatous inflammation. And you may see some hair shaft fragments as well. Remember that epidermoid cysts, and sometimes they can have pilomatrical differentiation. You may have lots of pilomatricomas and epidermoid cysts in some patients. Remember, that's associated with Gardner syndrome. That's a phenotypic variant of familial adenomatosis polyposis, or FAP. And that's due to a mutation in APC protein on chromosome 5. You will see adenomatous polyps, desmoid tumors, osteomas, as well as the epidermoid cysts and lipomas, dental abnormalities, and periampullary carcinomas. Here is just a epidermal inclusion cyst. You can see some punctum on top, some oxidized keratin at the base of that punctum. The epidermal inclusion cysts have that shredded wheat or onion skin, lamellar keratin, the retention of the granular layer, and stratified squamous epidermis along the outer edge, and you do not see direct connection of adnexal structures to the lining. Here you see the cyst wall resembling the surface epidermis, lamellar keratin, and when it ruptures, you'll get multiple giant cells, as you see here, this granulomatous response to keratin. You can see some cholesterol clefts and some keratin fragments that are surrounded by clear halos throughout. Again, here is your keratinized squame. So see the thin keratin fragment. It's kind of like just a cell. It kind of looks like a flake of just like some type of flake with this halo, and then you've got a very thin keratin, and this structure is pretty unique. So with the surrounding giant cells and these keratinized squames, even if you don't see the proper cyst, you'll still be able to make that diagnosis clinically. Just say granulomatous inflammation with associated keratinized structures suggestive of ruptured cyst, and leave it at that and say close clinical follow-up is recommended if there's any suspicion for a neoplasm. Pilar cysts are basically the cousin of epidermal inclusion cysts. It's also known as a tricholemmal cyst or isthmus catagen cyst. You can see them on the scalp. The epithelium resembles that of the outer root sheath, also aka tricholemma. You have abrupt keratinization with no granular layer. So that abrupt keratinization is important. It actually leaves you with this deeply eosinophilic, very dense keratin within the core, so-called bubblegum pink keratin, not to be confused with bubblegum pink collagen that you would see in a keloid. These commonly calcify, and there is a subset where you have autosomal dominant inheritance where these patients have lots of pilar cysts. 70% of patients have multiple pilar cysts. Clinically, these are easy to kind of just pop right out of the skin because they have that hard keratin core. So here is a low power image of a pilar cyst. You can often tell it's a pilar cyst before you even put it under the microscope because it looks so dense and pink, even just on the slide. On higher power, you see that abrupt keratinization or tricholemmal keratinization. It skips the granular layer and goes straight from the stratified squamous epithelium right into that compact red bubblegum pink keratin. A higher power view to show you. I often find that the keratinocytes are more plump and round here right at the transition zone. Proliferating pilar cyst, on the other hand, these often occur on the scalp, usually in 90%, often in elderly patients, women more than men. It's like a large, well-circumscribed cyst or a mother cyst with many daughter cysts inside. It's so-called rolls and scrolls architecture, which you can see here. There's proliferating epithelium, which buckles in on itself. There's a lot of tricholemmal keratinization. Again, that's why it's a proliferating pilar cyst. And you do have to entertain that you might be dealing with a tricholemal carcinoma. So look very carefully, because you don't want to miss something that at low power looks like a proliferating pilar cyst, and then you actually in reality have a tricholemal carcinoma with large rapid growth. These often will be bigger than 5 centimeters, multiple mitotic figures, multiple atypical keratinocytes. It's got an infiltrative growth pattern, etc. But many times, if it's on the scalp and it's well circumscribed like this, and at low power you have these really kind of circular areas folding in on themselves like a rolls and scrolls pattern, maybe some focal calcification areas, etc., you're dealing with a proliferating pilar cyst or proliferating tricholemal cyst. Another example here, very well circumscribed, a rolls and scrolls architecture, like multiple cysts within one large cyst. Just another example, even better example of a rolls and scrolls pattern here. Brachial cleft cysts often occur on the lateral neck. It's a persistence of the second brachial cleft or remnants of primitive gills. Stratified squamous or pseudostratified columnar epithelium are typically lining these cells, and the key is peripheral lymphoid follicles within the germinal center. So remember this underlying word of lymphoid follicles. That's important in making a diagnosis of a brachial cleft cyst. You may see mucinous glands and cartilage as well. So the outer lining of the cyst, again, it can be lined by these pseudostratified columnar cells, maybe even some stratified squamous, as I mentioned here. But the germinal center lymphoid tissue around that lining is going to be the most common scenario, and that's going to allow you to get it correct on your exams as well. Here you can see a brachial cleft cyst, again, highlighting that germinal center on the outside. Here, this looks like kind of thin stratified squamous epithelium or maybe pseudo stratified columnar epithelium. It's not really about what's in the lumen that's important. It's about what's on the edges of that cyst that's really important. Bronchogenic cysts, these often occur clinically at the midline neck above the suprasternal notch. This is considered remnants of the primitive foregut. You will find ciliated pseudostratified columnar lining. Think about the ciliation as being relating to the airway, so bronchogenic cysts. You'll look for goblet cells or mucus cells, concentric smooth muscle around the cyst. You may or may not see cartilage, and usually no lymphoid follicles. So here's that respiratory type epithelium, that ciliation, and the columnar, pseudo stratified columnar lining, and then that concentric smooth muscle, and you may or may not see associated cartilage around it. Clinically, the location of the suprasternal notch is important and testable. Thyroglossal duct cyst, this also occurs in the midline neck cyst, moves with swallowing. It's lined by respiratory or squamous epithelium, which can be cuboidal or stratified squamous. The key for you is going to be noticing the peripheral pink thyroid follicles and or lymphoid follicles. So here's that midline thyroglossal duct cyst, and here are your thyroid follicles. So if you see this, and you may see those lymphoid aggregates as well, but the key is the thyroid follicles. This is a thyroglossal duct cyst. You can see the cystic space as well. In this case, it's more about what you're seeing on the edges. So getting a digital slide of this or an actual slide of this, they're going to have to show you the thyroid follicles before you can make the diagnosis of a thyroglossal duct cyst. If you didn't have these thyroid follicles, it's going to be difficult, impossible probably to make that diagnosis. But if you do see them, you should definitely get the answer correct. Steatocystomas are multiple cysts that often occur on the chest, clinically look like nodulocystic acne. The epidermis often will have an eosinophilic cuticle that's wavy and refractile. Many people will call that a shark tooth crenulated cuticle, as you can see here, and we'll get to that. The other important point is sebaceous glands in the cyst wall. So here you see multiple, in this case on the chest, well-circumscribed cyst-like structures, little papules, skin-colored papules, or probably even some of them are a little bit big enough to be called nodules here. But the key on histology is this red shark tooth crenulated cuticle. And this is very characteristic of a steatocystoma. So even if I didn't have the sebaceous gland in close proximity, often I will see sebaceous glands directly connecting to the epithelium, but they're not really ubiquitous. What's going to be the most important thing, even if I don't see a sebaceous gland, is this red shark tooth cuticle or wavy crenulated cuticle. If you have multiple of these, think about Pachyonychia congenita type 2. This is a condition that presents with onychodystrophy and painful focal palmoplantar keratoderma with hyperhidrosis. This is often associated with the keratin 6B and keratin 17 mutation. What else do we see with Pachyonychia congenita type 2? Natal teeth is important for your test, and these patients may also have oral leukokeratosis, more so than Pachyonychia congenita type 1. So how are you going to feature the best, but how are you going to differentiate them between 1 and 2? Natal teeth is more common in Pachyonychia congenita type 2, as well as our steatocystomas. So steatocystoma multiforme, you're going to see this more in Pachyonychia congenita type 2. So if you saw this on your test, think about that genodermatosis. A vellus hair cyst also commonly occurs on the chest. It looks like an epidermal inclusion cyst. You can see it's lined by stratified squamous epithelium. And the key is in this cyst, the important thing is what's inside the actual cyst lumen. So the tiny vellus hair cysts floating in the middle are going to be able to make that diagnosis for you. So clinically, not really that impressive, just these small little erythematous cyst-like papules. On histology, you'll see multiple hair shafts all twisted up and intertwined within keratin in the lumen of that cyst. So it looks like an epidermoid cyst or epidermal inclusion cyst on the outer part. The key is what you're seeing on the inside that's going to allow you to make that diagnosis. This is highly testable. An dermoid cyst is commonly located on the head and neck. It's the most common location. And it looks a lot like an epidermal inclusion cyst histologically, at least with that stratified squamous epithelium. But the important key to make the diagnosis is the adnexal structures are present in the cyst wall. So clinically, this looks like it might be deeper than an epidermal inclusion cyst. You may not see a punctum. It's in that area right above the eye, very common clinical area, clinical presentation. You can see that it looks like an epidermal inclusion cyst with this shredded wheat onion skin, lamellated keratin, and retained granular layer with stratified squamous epithelium, but you can appreciate the direct connection of multiple pilosebaceous units. So it actually has adnexal structures connecting to it. And that's why you'll often see a lot of hair within the cyst as well, because the hair shafts from the adnexal units are going into the lumen. Many times I'll get rule out teratoma, rule out dermoid cyst because clinically they saw there was hair within it. And for me, if I don't see direct connection and I don't see a lot of hair shafts within it, it's hard for me to say that it truly is. But I'll say if clinically it was more of a dermoid cyst, I would say cyst compatible with dermoid cyst, which was the clinical impression. And if the clinician really wants, I can do deepers and really look for the direct connection if it's an important diagnostic determination. A median raphe cyst occurs in men from the meatus to the anus. Its lining can be variable, either ciliated, cuboidal, or show decapitation secretion. It's often filled with debris, and surrounding skin has characteristics of genital skin. So smooth muscle, prominent vascularity, small nerves, delicate collagen, etc. So here you see the debris-filled cyst, and there's often smooth muscle throughout these areas in between. And that lining, as I mentioned, it can be variable. So ciliated, cuboidal, or you may see decapitation, secretion, etc. So the important thing for this is you can't call it any other type of cyst, and it occurs in the men from meatus to the anus. So clinical in combination with what you're seeing here is going to be able to allow you to make that diagnosis of median raphe cyst. Other helpful hints is it's kind of got this irregular thickness as you go along. So it has areas of thin amounts of cells, maybe getting close to 1 or 2 cells thick, and then other areas it kind of looks more like it has more cells there. And then you can see that if you go in higher power, you'll be looking for ciliation or cuboidal cells, maybe some decapitation secretion, that debris. So combining what you're seeing here clinically and histologically will allow you to make the diagnosis, median Rathé cyst. And so we covered the major cyst types that you'll need to know for your exam. I encourage you to delve into the textbooks as well to supplement your knowledge on more about the different types of cysts, and also practice looking at many examples of different types of cysts, because you will see some cysts on your exams. Thank you for your attention.